stuff.
Okay, we're live.
Good.
Do you want me to start, or are you guys going to introduce me?
We'll do a brief introduction, and then we'll go over some technical details with everyone, and then Maggie will introduce you.
Hey, Nick, I think it'd be best if you take over the intro. My Wi-Fi is too sporadic right now, and I don't want it to be weird. So go, take it away.
Okay, so we'll go ahead and get started now.
Hey, Nick, I think it'd be best if
1 second. Everything's delayed here. So everyone, welcome to our second shadowing session. A couple things before we get started. We're going to send a link to our email list again in the description, so make sure you sign up for that so you don't miss any of our future events. There'll be a Google form at the end of this, so make sure you stick around. We'll send that link out. That acts as your validation, so you can verify your hours. And we're going to be taking a quick break after this session until 2021, give everyone time to study for finals, enjoy the holidays, and we'll pick it back up. We will be active during January. So during UMD's winter break, we still will have presentations, so keep an eye out for that. Otherwise, I'm going to introduce today's speaker, Dr. Timothy Egan. He's an otolaryngologist working in Fairfax, Virginia. He's board certified in otolaryngology, or ENT, as well as sleep medicine. So he's going to give us a talk today about his path through medicine, his journey to medicine, and kind of what it takes to become a doctor. So Dr. Egan, take it away.
Thank you very much. And thank you to the Shellcast group for inviting me to speak. I congratulate you all on having the foresight to put this idea together for clinical hours. This whole COVID crisis has changed the way we do a lot of different things. And I think this shows a lot of initiative and a lot of drive. And I hope it works out very well for all of you going forward. I want to give a little brief talk about the pathway that you guys are starting to go down, maybe some advice from my experience, and then tell you a little bit specifically about my career. There are literally numerous different pathways that you can all take in the medical field. So this is just one option there. So as Nick said, I'm currently a partner at Fairfax ENT, which is in Fairfax, Virginia. My specialties are ENT as well as sleep medicine. Hold on. There we go. So first slide. So here's a little slide that runs through the steps.
Dr. Egan, we can't see your slides. Can you share your screen, please?
Sure.
Thank you.
See what's going on here. All I see is can you see them now?
Yeah, we can see that.
All right, let me put it on a slideshow mode. Okay. So the first slide is just a general roadmap for sort of the path ahead for all of you. Some of you may already know this, looked into it, studied it, but for a lot of us who consider the path of medicine, it's something that we've considered since before we can remember. We just always sort of said, I want to be a doctor, I want to be a doctor, and followed the path along the way. not quite sure what that path really entails. So I guess in a year, year and a half, you all will be starting your first year of medical school. And that is actually a very fun and exciting time. I truly enjoyed my first year in medical school and all of medical school really. But it's just, you're working your tail off, you're studying long hours, but you're finally doing what you really love. And it seems like every day you're learning something that just makes you go, wow, I didn't know that. But the first year of medical school is normal. So you're learning normal anatomy, normal microanatomy, what they call histology, normal biochemistry, physiology. So you're learning the way the body works in a normal state. The logistics of it is very straightforward. There's a classroom of, in my case, it was about 120 people, 120 seats. And you would go to that classroom at 8 in the morning, take a break for lunch, and get out at about 4 in the afternoon. And you would just listen to lecture after lecture with the same group every day. So unlike college, where every class is a different group of people getting together, in med school, you all just stay together and you actually form a pretty close bond and good group of friends. I'm still very close and very tight with my group of friends from medical school. You also have gross anatomy lab, which is where you get your cadaver and you break down into groups, and you spend a lot of time dissecting, learning, and studying the cadaver. It is interesting, the cadaver is typically portrayed in sort of a comedic sense. When you watch it on TV, people play jokes with it and pranks with it. That's absolutely not the way that it is in the real world. They're revered, they're treated with incredible respect. Every piece of specimen that you dissect and take off is kept separate, and that will all be cremated together as the one body. So, you know, we owe a great deal of gratitude to the people who donated those bodies, and we treat them with the respect that they deserve. Year 2, you basically just move down the hall. You're in a different classroom, same group of people. And the big switch between year 1 and year 2 is now you're learning abnormal anatomy. So, or abnormal medicine. So pathology, what goes wrong? You know, what happens when the heart fails? What happens when the lung fails? What's cancer? What's an infectious disease? And how do we fix it? So you learn pharmacology. And that's a very interesting time for me, because for your whole life, you go to the doctor, they give you an antibiotic and you take it and you have absolutely no idea why it's doing what it's doing. And when you can learn it on a molecular and a biological level and be like, that's what it does, it's fun, it's exciting. At the end of your second year, excuse me, you take USMLE 1. So you'll see the arrow off to the top going off. That stands for United States Medical Licensing Exam, Step 1. That is basically one massive final for your first 2 years. You have about a month off to study for it, and then that board score is the most important board score for getting residencies. So if you want a competitive residency, you need a good score on that board score. Years 3 and 4 is when you finally put on the white coat. It's a short coat, but it's a white coat. And you head out into the hospitals and you start your clinical rotations. And you'll actually see patients. You know, typically what will happen is you'll see a patient, you'll take a note, you'll do an exam. That note will be followed up by maybe the intern or the resident's notes. You might present it to the resident or the intern, but you're not just shadowing any longer. You're not just following along. You're expected to come up with your own plan, your own diagnosis, and you're expected to learn and know what you're doing. Obviously, there's somebody watching you, keeping an eye on you, and keeping you out of trouble, but you're not shadowing. You're part of the team at that point. My one piece of advice is for those rotations is when somebody says, what would you do now? Do not answer with, you could do this, you could do this, you could do that. That's the standard insecure medical school answer. Give an answer You're the doctor, you're the person making the decisions. Say, I would recommend this. You could be wrong, but you're better off than just saying you could do this or could do that. Fourth year, you break down and you go into, so third year, to give you a general gestalt, is basically surgery clerkship, medical clerkship, pediatric clerkship, psychiatry, and OBGYN. So those are the rotations you're going to be on. By fourth year, you're doing probably what's called a sub-I or a away rotation. So say you decide you want to be an orthopedic surgeon and you really like to go to Chicago, you'll spend a month or so in Chicago doing a sub-I there where they can meet you and learn what kind of a person you are, and you get you a step up in applying to that residency. And then there's also other rotations in fourth year: emergency medicine, radiology, ophthalmology. So some of the rotations you won't even get a chance to do before you apply for your residency. So sometimes you have to be thinking ahead if that's something you want to do. You graduate, and then there's match day during your fourth year where you're going to pick a rotation, you're going to rank where you want to go for your specialty. You're going to say, I want to go to University of Maryland, number 1. And they're going to rank you. And if they rank you number 1 and you rank them number 1, you're going there. If they rank you number 3 and the first 2 people turn them down, you're going there as well. So it's a sequence where and it's exciting, but it's also, you have no control over it in some ways. I remember my experience. I matched in Boston and I had just been married for literally a month. And my wife was like, we're going to Boston? I'm like, yep. We have no choice. Then your residency internship year will be part of residency typically. Some people will say, you know what, I don't know what I want to do. I'm just going to do an internship year and get it out of the way. But most times it's part of your residency, and it will either be an internal medicine internship, general surgery internship, or a pediatric internship. Some things like anesthesia and radiology will allow you a choice between either medicine and surgery, and everybody picks medicine. Surgery is by far the hardest internship. It's only 1 year, but as the note says, it does seem longer. It's a tough year. Residency, that's actually, it says it's 3 to 6 years. It should be 2 to 5 years because I'm including the internship year in that. When you finish your residency, so let me back up a second. After fourth year, you're going to take step 2 of the USMLE. And at some point during your residency or after your internship year, you're going to take step 3 of the USMLE. The old expression used to be you study a month for step 1, you study a weekend for step 2, and you show up for step 3. And that was my case. I literally showed up and took the test, and you can go through it as fast as you want on the computer, and that's not a hard test. That's just part of the process. The first one is the tough one. After residency, you can either graduate, become fully licensed as a doctor. You've met all of the requirements. There's 3 requirements to become a licensed physician where you can treat a patient. You need an MD, and you got that when you graduated from medical school, or DO, but you need to have passed all 3 steps of USMLE, and you needed to have completed a residency. Once you have that, you get a license to practice medicine. You can also go on to further study and do a fellowship. And some people will decide to go get a job, and then after a year or so, decide to go back and do a fellowship. So you can come out and go back in. There's no problem doing that. The final arrow at the bottom is once you come out, 1 year after you graduate, you will take what's called your subspecialty exam for board certification. That is not required to practice medicine, but it is almost universally required to practice in any established hospital system or any reputable hospital system. So most times when you apply for a job coming out, it'll say, are you board eligible or board certified? Board eligible just means you haven't taken it yet, but you're going to take it. So medical school, we talked a little bit about. There's a few pieces of advice that I have for getting through medical school. The first one, I think, is the most important, and it's learn, don't cram. Try and just learn the material. You're going to go over it literally thousands of times, but once you learn it, you know it, and it doesn't go away, and you don't have to keep relearning it, because that same stuff is going to come up again in different formats and different venues, and it's certainly going to come up for step one of the boards. When you come to a green light, you know it's green. You don't have to go green, green, green means go. You just know it. And when you learn it and know it, your life's easier. Find a balance, and exercises for the mind and body are both sort of the same thing. You're going to study a lot. You're going to work a lot like you guys are doing now, but you're going to want to find some free time, some fun time, some vent to get out and enjoy yourself. When I put there's no points for trying or no points for showing up, figure out what works for you. If you go to class and just space out and it's not working for you, you might be somebody who, I had friends who completely avoided going to class because it was a waste of time. They would just get up at 8 o'clock in the morning, go to the library and start studying on their own. So there's not enough time in a day to just sort of say, well, I'm going to go to class, and you need to be working and getting productivity at all times. Make friends and work together. I mean, I think most med school classes, I hope, get together and form pretty tight bonds, pretty close friendships, and enjoy the journey. It's tough, but it's fun. Med school is great. It's a good experience. The final quote on the bottom is from an anatomy professor, and it sort of harks back to the learn, don't cram. The long thoracic nerve is a nerve in the chest, and it innervates the serratus anterior, which is a muscle that sits right below the pec. And one of the girls in the class was saying she can never remember that. And does the professor have a mnemonic to help her? And he says, I would prefer you just learn the information, but if you really need a mnemonic, try this one. Roses are red, violets are blue. The long thoracic nerve innervates serratus anterior. And I got to give him credit. I've never forgotten that little factoid. But residency, residency's tough. A lot of hard hours. You work hard, but you want residency to be tough. If you don't learn it in residency, you're not going to get another real chance to learn it. Particularly if you're in a surgical field, you want to be in a busy place. You want a place that has lots of autonomy. And what I mean by that is the surgeon lets you do the case. We would have cases where the surgeons would literally many times just leave the room, let the senior resident take the junior resident through cases. Once the patients were out of the OR, the attendings had almost nothing to do with the patient care. We did most everything ourselves, and that's really what you want. I shadow residents, or I work with residents where I am now, and we provide them with good training, but I got to say it's not as good training as I got. These are my private patients. I have to watch them very closely. I did 3 implant cases on Monday, and the resident's fantastic. He's a senior level resident. I let him do absolutely everything, but I got to watch him every step of the way, and I got to give him advice. I can't turn him completely loose. Mentors is important. When you pick a place, you're going to be studying under a small group of people. And maybe if it's a small field like ENT, you're talking maybe 6 or 8 in your department. So the people there is very, very important. And beware of too many fellows or fellowships. You may find that the senior residents don't get to do the cases because there's a fellow who wants to do those surgical cases. I just got a kick out of this picture on the left where the guy remembers his first time job. So ENT, I decided late in the game that I wanted to go into ENT. My 3rd year surgical rotation is 6 weeks of general surgery and then 2 weeks of a surgical elective. And we had 3 options. We had ENT, we had plastic surgery, and we had urology. And we had to rank them, and then it sorted out. And so I ranked plastics 1, urology 2, and ENT 3rd, and got my 3rd choice. I had absolutely no idea what an ENT did. And when I went on the rotation, I was just amazed at the breadth of the stuff that's involved in ENT, how much is possible to get done. I just didn't know there was that many things that you could do to an ear or to a nose. I had always loved the head and neck anatomy. I found that the most intricate and most beautiful anatomy. So it was interesting when I found this, and I knew I wanted to be a surgeon. So when I found out how interesting ENT was as a surgical field, it was a natural fit for me. You break down ENT and you can subspecialize further. Pediatric ENT is obviously children. Head and neck is malignancy, cancer. A lot of head and neck cancer, be it from smoking, alcohol abuse. Right now we're seeing a ton with HPV. That is a little bit of a dwindling field because radiation oncology is treating most of the HPV positive cancers, which are the bulk of the tumor right now because they respond so well. Rhinology and skull base is sort of the sinuses and the base of the skull where the sinuses and the brain meet. So there might be tumors that invade into the brain from the sinuses, and we'll frequently work with neurosurgery in conjunction where we'll approach it from the bottom, they'll approach it from the top, and we'll, as a tag team effort, we'll take out the tumors. Or maybe a spinal fluid leak through the nose that we have to go in and reconstruct and repair. Plastic and reconstructive runs a gauntlet from cosmetic plastic surgery, Botox, fillers, rhinoplasty, nose jobs, facelifts, and also reconstructive. We see a lot of skin cancers at defects. Some of them can be absolutely massive, where the defect needs to be closed. And also when we're doing head and neck surgery, a lot of times we're removing large sections of the tongue, the jaw, the cheek, and that all needs to be reconstructed. Frequently we'll use something called free flaps, which is where you're actually transplanting a piece of tissue with the bone or the muscle from another part of the body, and under a microscope suturing the artery and the vein together so it has a blood supply. Sleep medicine deals mostly with obstructive sleep apnea in ENT. There's a whole another host of stuff that sleep medicine does, but we tend not to get involved in that. We're just involved in the obstructive sleep apnea component. Neuroetology is another area where it's a border zone between brain surgery and ENT. And there's tumors that grow along the nerve to the ear, and there's cochlear implants. So there's all kinds of neuroetologic surgery that gets done. So this, some of you may recognize this picture in the background. This is the NFL Combine, which is obviously at before they draft day, they take all of the potential NFL players and they test them. How fast are you? How high can you jump? How much weight can you lift? This guy can jump pretty high. But there's always talk about the intangibles. They say, all right, well, this guy can do all of this and this, but what about the intangibles? And what they mean about that is that there's still something about a player that we can't measure that makes them great. And it's the same thing with doctors. I think in medicine, we're terrible about picking the doctors who have these intangible qualities to get into medical school. We're awesome at picking the ones that have the highest board scores, that have the highest grades, that've done the most research. But in the end, when you show up in a patient's room, it's those intangibles that make the difference. It's what makes a patient have a better experience, and it what makes you enjoy the job more. So some of the intangibles that I came up with, and there's a whole lot more, but I just wanted to cover a few. One is empathy. One is being a curious, lifelong learner. One is being observant. One is confidence. And one is humility/courage. And I want to put the humility/courage together because if you have courage and no humility, you're going to be dangerous. You really always need to have that humility because there's an old saying in medicine, in surgery in particular, that if you've done a certain procedure and never had a complication, that just means you haven't done enough of them. Eventually, complications happen. They should be rare. We should be able to learn from them, and we should be able to avoid as many as we can. But we always have to be aware that they could potentially happen, and we have to be aware what we do when they do happen and be open to them. William Osler, who was one of the grandfathers of internal medicine at Johns Hopkins, has a great quote here, which says, "The good physician treats the disease. The great physician treats the patient who has the disease." And I'm going to run through a few cases that I think emphasize what I mean by some of these different characteristics. This is a patient who I saw when I was in Bolivia. I was down there doing some mission work, and she presented with a thyroid mass, which is not hard to find. And the reason she was very scared and almost canceled her surgery, and you can actually, this picture I took on the day that I met her, a couple days before her first surgery, and her face just looks extremely stressed out. And she was extremely stressed. And her biggest fear was that she had heard from the villagers that if we take out her thyroid, her goats will die. And that makes no sense to us. There's no reason to believe that. But you still have to empathize with her position. She fully believes that, and her goats are her livelihood. And if they die, she doesn't know what she's going to do. So it's important to empathize, and it's important to be able to put yourself in the other person's shoes, to feel what they're going through. And sometimes it's just a matter of just hearing them out, listening to them, nodding ahead, but it can make all of the difference. But we were able as a team to put her at ease. And then she had her surgery. We took out the thyroid. To date, that's the biggest thyroid I've ever taken out. The thing is absolutely massive. These are some intraoperative photos. So anyone going into surgery, you'll see the incision here. This is the thyroid gland. And then off to the right side, this tiny little nub in here is another gland called the parathyroid gland. And we have to keep an eye out for that when we're doing surgery, because if you damage it, if you remove it, if you touch it too aggressively, I mean, you compromise its blood supply at all, it shuts down for a little while. And that's important for calcium metabolism. And I'll come back to that point in just a minute with another case. Anyway, her surgery went fantastic. And this is her the day after her surgery. This is me, and then Dr. Lee, who's one of the other surgeons. Him and I did the surgery together. And her face just looks completely different to me. I'm always struck when I look at this picture that the relief, the sense of calm that she's had. And she came back. I went to Bolivia, I think 3 years later. She came back and visited, and it was really great to see her doing so well. So this is another one, a patient that came in and had a thyroid mostly on one side. Now the parathyroids are on both sides, but we had wound up taking out both of her thyroid glands, both sides. And she did fantastic, and surgically everything went great. But we checked the calciums after surgery because of that gland we talked about, and her calciums were really low. So we gave her some Tums, which is mostly calcium. You know, when we're working in Bolivia, we're doing everything on the cheap. We don't have a whole lot of testing. We don't have a whole lot of medications. So we would just kept giving her Tums day after day. Calciums did not budge. Now we're getting ready to fly out in a couple of days, and her calciums are still on a dangerously low level. And my wife happened to be on that trip and was talking with this woman when I would be in the operating room. She got to know this woman quite well. And she asked me one morning over breakfast, she says, "Do you know where she lives?" I said, "I have no idea." She goes, "She lives in a dirt hut with no running water and no electricity. And every day she buys one small potato and has half for breakfast, or half for lunch and half for dinner." Now that's important because whenever we check calcium levels, we always check protein levels, because most of the calcium is actually going to be bound to the protein and not functioning. We just care about the on-bound. So there's a correction that you'll learn eventually where if the protein's low, the calcium can be low. And a light bulb went off, and I said, her calciums aren't low. Her calciums are absolutely normal. Her protein's low. So we stopped her Tums, let her go, and she was able to just go on with her life. And had my wife not picked up on that piece of information, I didn't pick up on it. I missed that. But since somebody was able to pick up on that and be observant and say, wow, she only eats 1 potato a day, we would have still been stuck with how do we manage this patient? And patient's not going to come out and say, oh, by the way, I have a low protein diet and that's probably why my calciums are low. You got to keep an eye out for these key things. Humility versus confidence. So this is the yin and the yang. Off to the left is what we call lap sponges, okay? They're basically gauze pads. A laparotomy is when you open up the belly, and so that's why they're called lap sponges. They come in packs of 5, and they always have a blue string attached to them. That blue string is supposed to be able to dangle out of the wound so you can find it, because you never want to leave one of these inside a patient. It's also what we call radio opaque. So that blue part there will show up on an X-ray. During the course of the operating room, one of the people in the operating room will count every single one, and they have these devices, these bags that line up with each bag in there. There was a surgeon where I trained who was Ivy League trained. He was vice chairman of the department. He was at the peak of his career, and he was really the forefront of what's called bariatric surgery or gastric bypass. And this was back when they were doing it all open. Now they do it mostly laparoscopic. So they would make a massive incision from just below the sternum all the way down to the pubis bone and open it up. And most of his patients were in the 600 plus category. I mean, it was a surgery for the truly morbidly obese. And at the end of one of the cases, they're closing up the belly and they're making their final incisions. And the nurse says, we're missing 5 lap sponges. And he says, they come in packs of 5. We're not missing 5. You have the wrong number of packs. And they say, well, let's open it up, take a look around. He goes, there's no need to open it up. We don't have to. The nurse says, well, I'm going to get an X-ray anyway. And they have that right. And they're supposed to. But unfortunately, with a 600 plus pound person, this X-ray over here is, a normal sized person. You can see down in the bottom right quadrant, there's a little white area. That's the radio opaque signal. In a 600 pound person, you can't see that the X-ray just doesn't have the power to penetrate all of that soft tissue and differentiate it. So it came back as unclear. No convincing evidence that there was a foreign body in there. So they sent the patient to the floor. And the big fear with a foreign body is infection. This is a 35-year-old man, 3 days later develops high fever and elevated white blood cell count. So they called me because the head surgeon said maybe he has a sinus infection. When I'm getting ready to see the patient, he goes into what's called Vtec Arrest, which is a rapid heart rate, and then his heart stops and he dies. They're able to bring him back, but he dies temporarily. They call the attending, they let him know what's going on. And then he says, we'll get ENT back there to take a look at the sinuses. By the time I get back there a second time, the patient is now arrested and died a second time, and this time was not able to be recovered. Obviously, the long end of the story was the autopsy showed 5 lap sponges inside the belly, 5. So here's where his doctor lacked all humility. He could not imagine that he could make a mistake. That's what other people do, not him. And because of his lack of humility, this young person lost his life. As an aside, he also lost his license and his job. But the real tragedy is that this person lost his life. He had every opportunity to say, oh, maybe I made a mistake. Let me check it out. And in my daily life, I have people all the time in the operating room who will say, do you want to do this? Do you want to do that? They'll keep you from making mistakes all the time if you let them. The people around you, trust them, work as a team, let them help you out. And be confident, but also have some humility. Understand that you can make mistakes. We all do. Lifelong learning is sort of the final thing I'll talk about. This is what I'm doing now is a new technique for sleep apnea. Sleep apnea is when your throat closes when you're asleep. So these patients typically snore, but more than snoring, they actually stop breathing, and it's an increased risk for heart disease, stroke, high blood pressure, and these patients are just exhausted. So a lot of them wear what's called a Cpap mask, and I'm sure some of you have some experience with this among family members, but it's basically a mask with a hose and it's pressurized and opens up your airway when you're asleep. Works great, but a lot of people can't tolerate it. So my patient population is patients that who are just at their wit's end, aren't sleeping, can't treat their sleep apnea. And in the past, we would basically say, we don't have an option for you. But there's a new device out that I've been doing, which is an implant that stimulates the nerve muscle, the nerve that moves your tongue. So this is a video of, I'm putting in what's called a sense lead, which measures the breathing. And that's going right on top of the lung there. So I've made an incision into the muscle between the rib space. And I place this device in there, which will measure the breathing throughout the course of the night so that the impulse can be given exactly at the moment that the patient needs it. This is now in the neck. This is the nerve that we're looking at here, and it's the nerve that moves your tongue. And the first thing I'm going to do is find out which branches I want, because obviously the tongue does a lot of different motions. I don't want to stimulate anything that's going to pull the tongue in or pull it to the wrong side. I want it to pull forward and stiffen up. So I'm putting a cuff on the nerve here in this video. That's the cuff there, and that's the electrode, which will actually deliver the stimulation there. And that's under a microscope, so that's magnified a lot of times. That nerve is tiny. And once that cuff is on there, then we can stimulate it. And once we stimulate it, this is a patient under anesthesia, so they're not moving their tongue voluntarily. This is us doing it for them. And when that tongue pulls forward, it opens up the back of their throat and gives them a nice wide open airway. It eliminates snoring. And it's been really a game changer for my patients with sleep apnea. So this is my data. I've done 65 of these implants so far, and this 34.7 would be qualified. That's a number of times per hour that these patients stop breathing. That is severe. Anything above 15 is severe. And these are patients who have failed all other modalities. My post-treatment is 4.7, which is normal. So we were able to get these patients from severe to normal. And this is a device that wasn't around. I mean, it got FDA approved in 2017, I think, 2016. So it wasn't even around when I was doing a residency. So part of medicine, it changes so rapidly that you get to learn. And that's the key to being a good doctor, but it's also part of the fun of the job. So I actually think there's a lot of rewarding aspects to being a doctor. And sometimes they don't get the recognition. People talk about the hard work, how hard it is to become a doctor, and it is. But people continue to want to do it because it is a great career. You get to love what you do. You have an opportunity to help others in need, both locally and globally. I've had the opportunity to travel to Bolivia 4 times and to Haiti and to perform surgery there and meet people and help people. But I've also had the opportunity to help people just in my office. I've had several patients show up who had no insurance but have large cancers, and I'll just, we'll make arrangements. And I remember recently this patient needed a tongue resection and needed a free flap, which I don't do. So I called up one of my friends and I said, "Hey, how do you feel about doing a case for free with me?" He's like, "Okay." So him and I spent about 12 hours and were able to get this guy the care he needed. And it's really rewarding. It's why you do what you do. You have to do the other stuff, but you want to do the stuff that's rewarding. And as much as you put in, you get a lot more back. There's constant room for growth and betterment. I don't care if you do the same procedure every day, you're going to get better and better at it. And there's also an ability to alleviate patients' pain and suffering. And that might be as simple as listening to them. You know, sometimes patients, I'm seeing a ton of it now with COVID, where patients are coming in just stressed out and anxious. They swear they have cancer, they swear they have this. And if you can just reassure them, they listen to you. Your word is the word. And they walk out feeling better. Mark Twain said, find a job you enjoy and you'll never work a day in your life. You still work, but it's good work. Any questions?
Yeah, we have a bunch actually.
Awesome.
Yeah. The first one's actually about residency, going back to the first part of your presentation. What can you do to match at a competitive program? Like, what should you do during med school to get into that residency of choice? And
Yes.
what bodies to consider? Yeah.
I was fortunate in the sense that ENT is one of the most competitive residencies, and I didn't even consider it until third year. When I went into my first year of medical school, the dean said, let me tell you a little bit about you guys. And he started lifting off the accomplishments of everybody in the room. And as he did, I just sank deeper and deeper into my chair. I'm like, I've done nothing. I don't belong here. And I was convinced I was going to fail out. So I studied my butt off for the first set of exams and wound up doing well. And then I was like, well, I'll just keep doing that. And so some schools are, where I went to school, it was pass-fail, but it's pass-fail honors. If you want a competitive residency, you need to be mostly, if not all, honors. And so that's so the grades do matter for competitive residencies. And when you go to schools, they'll be like, no, grades don't matter, it's pass-fail, not for the more competitive residencies. That's number one. Number two is getting a good grade on your USMLE step 1. And if you crush your first year, you study it and you really learn it, you're going to crush the USMLE because it's exactly the same stuff. And the final thing is, when you go to these places, work hard, show up. Residency is a lot of hard work. It's a lot of initiative. So they may say things to you like, oh, don't worry, you guys don't have to round on patients ahead of time. Do it. Show up ahead of time, get it done early. They'll be like, make it like the 1 month of your life where you work as hard as stay late, get there early, and have a positive attitude, and never ask a question that is not based on something. So, if you have a case on a schedule that says a removal of a pleomorphic adenoma, don't say, what's a pleomorphic adenoma? Say, I was reading about pleomorphic adenoma and I saw that it's a benign tumor. Why are we removing it if it's benign? Totally different question.
Absolutely. What you just described sounds like a very intense work environment, as we all know. How do you personally prevent burnout when working at such an intense level for so long? During residency, it was tough to prevent burnout.
But my life right now is not that hard, to be honest with you. There's not a lot of evening and weekends. Most of my patients are outpatient. So I don't have patients in the hospital where I'm rounding on them before work or after work. So the ability for me to have surgery in a surgery center where they go home the same day, it makes life very, very manageable.
Absolutely. One of the other most requested questions was, how would you describe your work-life balance, which is really related to that?
Very good. Yeah.
Any tips for maintaining that, or?
Well, you can only do it in certain fields, I would say. Some people say like, oh, I want to be a cardiac surgeon, but I want to have a good work-life balance. Very, very difficult when you have patients who are, fresh off the pump, off a bypass or a transplant. You got critically ill patients in the hospital. You got to be thinking about them. You got to be worried about it. You got to be checking in on them. So some fields are more prone to it than others.
Absolutely. One question that I had that popped up during your presentation is you mentioned lifelong learning and this new technique that you just started a couple of years ago. How do you go about learning something new without that kind of guidance and learning environment like you do in a residency situation?
It has to be a lot more self-motivated. I didn't develop the technique. I'm just, this came out and was FDA approved, and I approached the company that does it because I had been following it pre-release and knew that I wanted to get involved in it. I was confident it would be successful. But yeah, there's a lot of, you'll, in a surgical field, to be like, I read about this way to do this procedure, and you'll just do it. Read about it and do it. You have the skill. By that time, you have the skill set. You know what you're doing.
Yeah. Okay. Well, one of the related questions was, how do you choose which nerve branch to stimulate when implanting this device? And does the same technique apply to each patient, or does your technique vary from case to case?
Same technique applies. The anatomy is different in every patient. They don't make it easy for you when with anatomy. There's huge variability. But what we do is we put a nerve monitor, so a needle electrode in the tongue branches. We'll put one in the side of the tongue and one underneath the tongue. And one of those is the muscles that we want to include, we call inclusion, and one is the branches that we want to exclude. And I have a stimulator that I will actually place on the nerve and stimulate it. And the machine makes a different beeping noise. So I can say, good, I want that one, don't want that one, I want that one. And then once we put it on, we test it.
Cool. Next question we have from our audience was, could you talk more about sleep medicine and other fields besides ENT that would complement this specialty?
Sure. So sleep medicine is not its own field per se. It kind of is a specialty that involves, you can be ENT, pulmonary, neurology, psychiatry. I think that's it. And be board certified. And we all sort of have a contribution to it. ENT has been primarily the surgical management of obstructive sleep apnea over the years. There's all kinds of procedures that have been done over the years. Pulmonary got involved in it because pulmonary also does critical care, which is ventilators. And the Cpap is basically a type of ventilator. So they're the ones who originally developed the pressure modality for treating it. Neurology, there's a lot of what's called parasomnias, which are patients who either have nightmares, sleepwalking, sleep fighting. Actually is a condition where you wake up and you beat the person up next to you, which can be very discouraging. And so they're the ones who get involved in that. And then the psychiatrists kind of get involved in because of the insomnias and the stress induced and that kind of stuff. So there's a lot of that in medicine. People say, well, who does this? And there's overlap. It's variable.
Absolutely. Now, you said you were board certified in sleep medicine.
Mm-hmm.
Was that a later decision in your career, or did that come right after?
I was doing sleep studies, reading my own sleep studies, which are overnight events where they do about 12 different channels of brain waves, heart rate, all this stuff, and we see if you have sleep apnea or not. And I was reading a bunch of those for a sleep lab nearby. And at that point, they said that this will be the last year where you can take the boards without doing a sleep medicine fellowship. So I said, well, I'm going to take the boards. Get them, so I was already doing it. And so you had to take the board. So that was a lifelong learning, because all I cared about was the sleep apnea component, but I had to go and learn all of the other stuff. So it was a long process to learn it and take the boards and pass it.
Absolutely. Lifelong learning was one of the intangibles that you mentioned, and another one of them was confidence. And I think confidence goes hand in hand with decision making. And one of the questions we had about that was, do you remember a time, or could you describe a time in your career where you were asked to make and justify a difficult decision?
Yeah, all the time. Yeah, well, I mean, one patient I can think about was a patient who had a thyroidectomy in Bolivia. Not when I went to Bolivia. She went to a different city. Unfortunately, she came and saw a surgeon here. Didn't have insurance, so she went to her home country, which is in La Paz, Bolivia, and they damaged both of her vocal cords, and she wound up with what's called bilateral vocal cord paralysis. So her airway is extremely narrow and very tight. And I tried a bunch of different things to get her better, and she wanted to go home and visit her family. And I agonized over that decision because at La Paz, it's at 14,000 feet. I was like, I don't think there's going to be enough oxygen for you there. But at the same time, by putting my foot down and saying that, I'm preventing her from visiting her family. So yeah, it's a tough decision because you want to do what's safe and right, but you don't want to take someone away from their family. Absolutely.
What did you end up doing in that situation?
I sent her down with oxygen, supplemental oxygen. And I offered to put a tracheostomy in before she went down. To be honest, she refused it. And eventually we wound up sending her down with supplemental oxygen. And she had a tough time down there, but she survived.
Good, absolutely. That's great to hear. And it's a great compromise, it sounds like, in favor of kind of what's best for the patient. Along what the intangibles we've been talking about, how do you recommend highlighting these intangibles in your interview or your application?
I think that's a good point. I think it is tough to, I think it's more, they're going to see it when they meet you. And maybe through your experiences. Some of them you can do through your experience. I think one intangible would be the people who are involved in this today, who have taken the initiative to say, you know what, there is no shadowing. Instead of just saying, what am I going to do? There's no shadowing. They said, all right, well, let's figure something out and let's make a better system. Let's deal with what we have. That's one of the intangibles. And I think that in an essay will prove itself. How you show it to the patients is probably the more important. And that's very teachable. And I've come 180 degrees on this. When I was a medical student, they would try and teach us, empathy. And I was like, you can't teach that. And I just wanted to get and learn real medicine, And in the end, that was really one of the more valuable classes. And one thing they tell you is when you ask a patient, just don't interrupt them. Just ask them a question, what brings you here today? And let them talk. And the big fear for doctors is that they're going to talk for an hour and a half. But they've done studies and patients will go on for like 23 seconds before stopping. It's not a long time. And they feel like you're listening. So you can learn those skills and you'll be taught them. You'll have some of them on your own, but you'll learn some tricks and techniques to make it more obvious that you are empathetic.
That's actually really interesting. I've never heard anyone talk about how these things are teachable, but I think it's a really good point and something that med schools should focus on as well.
They do focus on it a lot, and it was just starting when I was in medical school. And like I say, I was not a big fan, but I've completely changed my mind on it now that I've practiced, and I use those skills all the time. That's
cool. A lot of the stories you've told today were about your mission trips, and one of the questions we got was, how often do you do these types of things, and is it a common thing, and how'd you get involved in mission work?
I've done it 6 times total, and I'd like to do it some more. It's a big commitment. We usually go down there for about 10 days at a time, and you're down there and you're operating pretty much nonstop or seeing patients. But you come back recharged. You learn a lot while you're down there, and you have a new perspective on life. So you really do get more out of it than you put in. And there's plenty of opportunities. Again, you got to go looking for them, but there's plenty of opportunities.
That's cool. That's really cool. One of our last questions that we have from the audience is, how has COVID personally affected your day-to-day routine? And can you take us through one of these average days?
Yeah, so for us, we are a very high-risk field in terms of COVID exposure. Because we're obviously in the face, in the nasal area. So, but at the same time, in the very beginning, we made a decision as a practice that we can't close our office and do things by remote, because what happens then is these patients just wind up going to the emergency room, and that's the last place the patient wants to go. And it's the last place the emergency room wants is to be overrun with these. And part of being a doctor is doing what's right by the patient. And I think, you want to be safe, but you have to take care of the patient. So we've developed a good system where we have someone in front of our office who screens and measures temperatures and asks questions. I personally wear a N95 mask all day, every day. We've had no cases in the office. We don't see COVID patients. So if someone thinks they have COVID, we're not the right place to come and get checked for it. But we want to keep going with everything else that we normally do.
Gotcha. I'm glad to hear that there hasn't been any cases. It's really good news. Our last question for you is, if you were sitting where we are right now, what advice would you have for the pre-meds tuning in?
So I think probably nothing unique, and unfortunately, it's super competitive now. Grades, MCATs, I think, are still crucial. All of the extra volunteers, this type of stuff, showing some initiative. But don't be discouraged if you don't get in the first time. I know plenty of people who have gotten in their second or third time. And medical school, when you come into your first year medical school class, I went 4 years college, 4 years medical school, back to back. And I was by far the youngest. I mean, the average age, I think, was 28 in my med school class. There was someone who was 50 in my med school class. So it's highly variable. People had full careers before they went in.
All right, that is all the questions we had, or we have time for. We can go through more if you're open to it, but
I'm open if you all want to stick around, whatever you all want to do.
I think we're all enjoying just listening. But this, I don't know, what's the plan from the rest of the team if we want to keep going?
Well, I think we're gonna wrap up the session now. So Dr. Egan, thanks for presenting. Those were great points he presented, and great job answering the questions. Thank you for coming out.
Thank you for having me.
Yeah, of course. To all our viewers, we're going to drop the link to the Google form in the chat right now. So make sure you fill that out, get that right, and you'll get the certificate to validate your hours. Keep in mind the email list is in the description, and then we will be taking a break for finals and the holidays. So we'll be back the first week of January. So keep an eye out for those presentations. Other than that, thank you guys for coming out.
Thank you, Dr.